on which many questions have come in, so I'll just read them out. But I think it should also be an opportunity for you to ask each other some things which are there. We don't have too much of time, but we'll try and listen about 10 to 20 minutes, and then I will need about 5 minutes after that to introduce my team to all of you. So we'll start with Catherine. Your session was the first one. The trajectories are very interesting. How much does the quality of intervention and parenting affect this trajectory? This is a question from Akila.
One of the hard things is that in a longitudinal study, all we can do is keep track of what people have. So in our study, we have hundreds of data points about who had what intervention when, but it's not randomly assigned. It depends on the region where people lived. It depends on the kind of insurance the parents have. It depends on a lot of things. It also depends on the kids. For example, we had 21 kids who had intensive ABA. They didn't do any better, and in fact, did slightly worse than other kids, but we could tell from knowing them before they had ABA that they were kids who weren't making progress, and therefore their parents sought out more intensive treatment. And so it wasn't that the treatment made them worse, it was that because they weren't doing well, they had more treatment, and the treatment didn't radically change their trajectories. I think that the only things we can tell about quality are the kinds of things that I mentioned. For example, we found that families that could find one provider that they stuck with, so, one person or group that they saw repeatedly over a year, did better than families who moved from therapist to therapist. Now, whether that's the therapists, that they keep getting therapists that aren't great with their kids and they get somebody else, or whether the family is having a hard time accepting that this is autism and going from person to person, we can't tell. So in that sense, our one interpretation, at least my interpretation, is that it was the quality of the therapist, not so much the specific therapy, whether it was speech or OT or ABA or teach, but that somebody who the family felt were valuable enough to keep going to see had some effect, whereas other people just didn't match up with their child. But again, it also could just be the parents. It could be that parents who seek out a therapist and find a really good therapist, even if they didn't find the therapist, might be able to support their kids in ways that result in more change. And I think one interesting thing about that finding was it was true, the kids whose parents did this had IQs of about 15 points higher than from where they started. Even if they were very low, it went up. If they were very high, it went up. Their language went up. They had less irritability. All across, they had better academic skills, again, across the board. So I think that was one of the things that we were really struck by. I think there are millions of other treatment effects. It's not that treatment doesn't make a difference. It's just that in our study, who got what was so out of control, out of our control, out of their control, that we just can't tell.
Good. Thank you. Efrat, which were the IQ tests which were used to collect the data, and which tests could be used for children who are nonverbal?
Whoa. We have combined our own tests. We didn't use standardized tests, okay? But I conduct research on our program, and we do use tools to assess the quality of life during the different points in the program, and their working skills and so on. But what are our criterions? First thing, we check that guy or girl can maintain a secret. They understand what a secret is and they can keep it because they're dealing with classified information. So this is one of the first things that we have to seek for. And as for communication skills, there are some participants, some soldiers in our program that hardly speak. They hardly speak. It's a very, I sit and we have this conversation, and I ask a question and I receive one word. And I ask another question, and it's open question, and I receive another word. So I think their cognitive level is normal. This is, but we haven't even checked that.
Okay, good. Dr. Menon, this is, if circuits for social interaction are weak in children with ASD, what could you recommend to strengthen these circuits? And also, have you looked at pre and post intervention results, and if it is reflected in the scan readings?
We haven't done any interventions, although we have plans to look at this particular circuit and how it changes and whether there's heterogeneity in how the interventions work out, and this circuit actually maps into that. But this is, some sense part of the PRT training programs, which rely on reward and essentially reinforcement learning, but that's conditioned to the child's area of interest. And so the broad class of PRT studies actually fit this bill, and there's some early indication that the reward circuitry is actually impacted and can change. And so there's going to be more research on this, building from prior work, PRT work, and some of the circuits we've identified now.
Good. Dr. Gagan, Joshi, how do you diagnose level of glutamate activity, and are these tests commercially available?
Can you repeat that part?
How do you diagnose the level of glutamate activity, and are these tests commercially available?
Glutamate activity? Glutamate.
Glutamate.
Okay. So the glutamate activity, and this is a very interesting question, but it's not globally available. So they do MR spectroscopy. What they do, they collect the data from a certain region of the brain, and then you need a very specialist physicist who can then take the data, create spectras, and then on the spectra, there's a glutamate spectra. Interestingly, typically, what the spectra they're able to get is the glutamate and glutamine. And glutamine is the inactive compound, and the spectra, the peaks being so close that other centers are not able to separate them out. At McLean Hospital in Boston, they're able to separate them out and only look at the glutamate, which is what we can call as absolute glutamate. So that requires that specialized physicist to do that. I don't think we have generalized this yet, but at this moment, it's only available at McLean Hospital in Boston.
Gita, what's your opinion? It's a tricky question. What's your opinion about comorbidity? Whether autism caused the morbidity or the background of morbidity caused autism?
I don't know.
Huh? You don't know.
I think it's a hard question. It's probably too
Would
hard
anybody
for
else want to respond
answer.
to that?
I think it depends. I think the answer is it depends. So, go ahead.
Okay.
Cause and effect.
Yeah.
Okay. So can I answer that? It was quite interesting in her presentation. She was giving the behavioral symptoms, and then what was missed was the medical diagnosis. I, as a psychiatrist, because I think beauty lies in the eye of the beholder who's listening to it, I could easily see also how the psychopathologies are equally attributed to autism as a core etiology, an expression of it, than as an independent entity in autism folks. I think if the autism is diagnosed early, as she said it, there's a diagnostic overshadowing, which is now becoming a little bit less common, but it's still there, then everything what follows it becomes somehow related to autism. I don't know whether it's chicken or the egg, but I do know that if you identify some of these comorbid conditions, then there are very good treatments available for it. For example, ADHD. ADHD has excellent treatment for the symptoms. And if you can separate them out from autism, then you find that kid will also be more focused in the behavioral interventions of autism, and it may also help treatment of autism, per se. We just finished a randomized trial in adults with ADHD with spectrum, and we found that the treatment was as effective as you see in the typically developing population.
Yeah, there's just one more which you could add to is, are you aware of any recommended protocol of medical tests that is available to pediatricians and developmental neurologists that they can use for children with ASD?
All I'm aware of, and I stand to be corrected on this, is the published standards of care. I think it's possible to very, very easily do better, like 2 orders of magnitude better than that, because all of these are diagnosable through standard means. If we can go back to the previous question, yes. My answer to it would be I think, these are large global questions, but in my personal experience, the answer seems to be it depends, because I'll give one example of a child with a disorder of folate metabolism. So he had cerebral folate deficiency. It was a profoundly affected child, seizures, lesions in the brain, couldn't speak. Once that metabolic state was corrected, that this child is nearly neurotypical at this point. So the honest answer is it depends.
We'll do one more quick round. I'll start with Catherine again. This is, let me just, as the questions become, this thing just moves up and down, but let me just pull out. Yeah, in the development trajectory, and this is very similar to what was asked earlier, in development trajectory, is there any particular clinical feature like better nonverbal communication at 2 years, which can predict a better outcome at a later age?
If we look at the 2-year-olds, the kids who did have, especially some receptive language, did better. But there's a huge array. So there are kids at 2 who you really can't tell if they understand anything, who do develop better. Predictions were much better at 3 than at 2. And again, probably 3 is more like 3.5, because we met these kids when they were 2.5. So tiny differences in time in young kids make quite a difference in terms of interpreting things.
Efrat, do the individuals have coaches in the trial period to work with them? Are there coaches who are there with, I know you talked about people who would intervene, but are there coaches? And also, do the professionals go through a specifically targeted prerequisite skills in special education, time management, reading, writing, etc.?
So our soldiers don't have a specific coacher, but our team, and what we see that there are some soldiers in the unit that learn how to connect and how to interact very good with our soldier, and they become like their mentors, okay? And it's like a natural gift that they have. And so they don't each have a specific coacher, they just go and work, and they find, the other soldiers find them, actually. And it's very beneficial for both sides. And as for our professional team, most of them, but the youngest have their master's degree, and in their studies, whether it is psychotherapy or occupational therapy or speech therapy, and some of them have majored in autism. So they did their masters in autism. So we have and we built money management groups, relationships and intimacy groups for our soldiers. We build our content and we teach them.
Great. Dr. Menon, these scans are commercially available. As these are routine MRIs, I guess the challenge is to read these correctly. Are practitioners available for the same who go into this depth of reading these scans?
Usually, neuroradiologists read structural images, and you don't really see any clear signatures of autism in these type of images. With a lot of data processing and machine learning tools, you can try and uncover some differences, but they're not likely to be of diagnostic value. In terms of the functional MRI scans, I think there is some hope that we can actually try and tease out subtypes in this data. And so now through the what's called the ABIDE consortium, they've actually made data from multiple sites. There are about 1,000 data sets, and that's kind of growing every few years. And so there is hope that as the data size increases, we'll be able to actually mine them and use them with deep learning and other machine learning algorithms to identify and predict and so on. So there's hope, but I think there's need for more data to capture the degree of heterogeneity in the sample.
And Dr. Joshi, high-functioning autistics may also be non-verbal. IQ tests cannot correctly identify intelligence in autism. Isn't adaptive functioning a better indicator of high-functioning versus low-functioning?
Well, so yeah, high-functioning autism can also be nonverbal. I completely agree with it. But the majority of the high-functioning autism, which comes to our shores in our clinic practices in psychiatry with emotional behavioral difficulties, are actually have very intact language skills. Their IQ, if done in the past, is within the normal range, and they're very socially curious. Actually, the tragedy with them is that their social desires is the one which puts them in more social challenges. If you consider say the Rain Man on one hand, and then the other one would be say something like Steve Jobs. I mean, he's not. If you read his book, you get a sense of that gentleman. The Rain Man is the one who doesn't suffer from autism. It's the family suffers from that relationship which is lacking with the Rain Man. But the Steve Jobs kind of person, or someone, I'm forgetting the name of the movie, or Big Bang Theory. Have you all seen Big Bang Theory? Anybody has seen the show? I mean, these are the people who desire social interaction, and yet they find it challenging, and they are in the midst of other kids who are socially typically developing and skilled. So those deficits do show up there more, and sometimes those things become the trigger. Transitions become a trigger, social challenges become a trigger, sensory dysregulation, sensory overload becomes a trigger, and those are the triggers which show then in emotional dysregulation or anxiety or worsening of the attentive issues, and that's how they present to us. So this is the population I deal with.
Gita, this is, can you please explain about Menon, how it helped? Should the children with autism start with it? Who is allowed to prescribe this drug?
Okay, so I can speak to my child's case.
Yeah.
In my child's case, it was prescribed by somebody called Michael Chess. To my knowledge, he was one of the first people to try this drug in autism, and his belief was that the clinical indication was inflammation in the autistic brain called neuroinflammation, and so it was a diagnostic trial really to see if my son would respond. And my son was a typically developing kid till he was 2.5. He's had regular MChats done, never any red flags, and he regressed literally overnight. And he lost all of his receptive language. He wouldn't turn when he was called. And so we started Menon when he was 4 on a pretty low dose, and within a month he was responding to 2-step commands. So it was miraculous, and I've had the opportunity to interact with a number of parents who've tried this with their kids and kind of follow them over the years. There seems to be a subset of children who are incredible responders to Menon. I don't have a really good handle on the subset, and if I were to speculate, I can tell you what markers I have for my own child, but if I were to speculate, there seems to be some correlation to seizures, as well as identified, like medically diagnosed mitochondrial deficits. In my son's case, and this is a question, I'm not sure if I'm supposed to be asking questions, but this is a question I have for Dr. Joshi. We did a lumbar puncture because of the suddenness of his regression, and one of the markers was CSF glutamate, and even after 3 years on Menon, it was still over twice the upper limit of normal. So I don't know if that is a biomarker, because my understanding is glutamate is managed in compartments. I don't know if CSF is a marker, but that seemed to be a marker that proved out for at least a couple of kids I know.
Sure. So let me give a small synopsis of some of our findings from the study. So I told you that 60% had high glutamate and 40% didn't. So we looked at a phenotypic marker. Is there a marker which is associated with the high glutamate versus the not high glutamate? And we didn't find any clinical symptom of either autism or psychopathology which was more or less in any with or without autism. So there was no phenotypic marker which could tag to the high glutamate activity. Also, in the responders, remember we talked about the emotional dysregulation, and we tracked emotional dysregulation as a response too. There was no change in the emotional dysregulation per se with the treatment of glutamate. It was only significant for social deficits. So glutamate as a marker, which I want to remind people it's a small trial. We have to do a larger trial and a prospective one to see if it's a true marker or not. But it could serve as a marker of therapeutic response. May not be the disease, we don't know. But as a treatment responder, that you said the subtype could be a high glutamate autism subtype, be the one which is receptive or responder to the memantine treatment versus not high glutamate activity. As far as the glutamate levels go, sure. I mean, looking at glutamate CSF is a kind of a little bit of a peripheral marker. But the glutamate activity, we looked at the ACC, which is pretty much at the area of activity of glutamate, was pretty high in them, and it came down with the improvement in autism behaviors, or with the no changing in the autism behavior, the glutamate did not shift. Seems like it is highly correlated with autism behaviors per se. One more thing I want to mention about glutamate. We also had two other areas in the brain, MTLs, left and right, to see if the glutamate activity there also was high, or did it shift with treatment or not. Actually, the glutamate activity in these regions, left and right medial temporal lobes, were within normal limits. They did not shift with treatment at all. So it seems like it's a very specific area in the brain where the glutamate activity is abnormal with autism.
Did you probe a correlation to seizures in the kids with high glutamate or abnormal EEGs?
So I think here are the things that medical comorbidities, psychiatric comorbidities. I think the high-functioning autism and not high-functioning autism are two different types of autism. In our clinic, we have more than 1,500 families with autism, and I can tell you that very few of them have seizure disorder or any GI abnormalities. It seemed like the comorbidity of medical illnesses and the psychopathologies, that profile is very different in high and not high functioning autism. They may share the same correlates, but they have different comorbid conditions associated with them.
Great. I'm going to ask each of you a quick question before we wind up. Dr. Catherine Lord, will we get a tool which tells us what the strengths of a child with autism are? Today, a lot of what we do is saying that this is not there.
Yeah.
Is there something which will say, this is there, and this is something which you can develop, or this is something which you can focus on?
I don't think there is a specific tool to do that. I mean, I feel like we use the ADOS to do that, but I feel sort of bad, because I think the reality is many people use the ADOS just to do a diagnosis. But the reality is, if you have a good clinician and 45 minutes with the child, and you've done hundreds of these, so you don't have to think about what you're doing, one of the things you do get to see is, what can this child do that is good, and how much do you have to help them to get them to be able to do things. So I think, I feel like that's probably as important a part of a diagnostic assessment as it's probably more important than the label. And I think that you can do that also in cognitive testing. You know, if you're using a measure that involves a variety of different tasks, you can see, what did this child do well, and go with it. So I feel like that's very important, but it's often emphasized because people get so focused on did they meet threshold.
So it's the way you look at it,
right?
Rather than what
You're actually
doing.
I mean, it would be nice. We don't have any measures that show people being better than you'd expect. They're always worse. No. So I think people are trying, I mean, you can do that a little bit with the adaptive skills, for example. You can say, these are better than I might expect. But mostly our measures are focused on, because kids with autism are so off the charts in some ways, then to get them onto the chart, we have to focus on the things that they can't do. And I feel like that's not a complete assessment, because we do want to know strengths, absolutely.
Efrat, the kind of work that you've done with the Israeli army is remarkable. Okay? And I got to meet her when I was in Tel Aviv and met some very senior people there. Now, the big change that happened was when three of you decided you want to do that. Is there anything else that you think you would like to look at, which you think will make a big difference? Because the impact of this, it's talked about everywhere. Given a chance, which other area would you look at? Because I know in this case, it was Tamer's wife going and telling, you now have the power, do something, okay? Is there anything else that you think should be done? Because there are many people here who are practitioners, some powerful people who are lobbyists, very senior people. Is there anything like exactly what happened in this case that you think should be done?
If I understand your question right, then I think anything is possible if your heart is in the right place and you're doing something that is right. Because integrating people on the autistic spectrum within the army, it sounds like a crazy idea, okay? But I think it's not only in the military. We can do it in workplaces, like employment programs, in all kinds of jobs and tasks and so on. I think you need to have a dream, you need to feel it's right, and you can fulfill it, and then it will happen. I don't know, and I think that's that.
I mean, I think it's just a passion and the determination with all of you worked, which brought this out.
Yeah.
Gita, one big change you want to see, which you think will impact children and families which have autism?
Can I say two?
Please.
Okay. So I would like to see significantly more robust standards of care, and I would like to see training. I'd like to see that manifest in clinical practice as better training on the standards of care. So that's one. And the other is that in the research realm, I'd like to see interdisciplinary collaborations and much, much more translational research, and also just basic research that dovetails well and leads to identifying therapeutic targets for translational research. So in a nutshell, better standards of care and more interdisciplinary translational research.
Good. Dr. Joshi, you're a clinical practitioner, but you've been working with the high-functioning groups. Is there anything which you're planning to do, especially for us in India, the high-functioning group either gets skipped out, or we always look at the low-functioning groups as the areas which a lot of focus is going on. Is there any work that you're planning in that area, or which you think is going to have an impact in India? I know the work you do is remarkable. We've met before. Remarkable work. Is there anything that is being thought about to look at what's happening in the low-function area?
So I think one area, which is a global issue, is better recognition of this condition way before it sort of goes past early adolescence, so that we
you
can...
talked about the adolescent period.
Yes. So it would be nicer if they are diagnosed earlier than a latency period or earlier in the preschool years, so that one can start sort of working, helping them with the social skills aspect. And we are nowhere close to it, honestly. I think we still wait for the social challenges to become way beyond their social capacities. And that's a little too late. That is one area. I mean, I see a lot of patients here in India when I come, and a majority of them are cases appearing to be very complicated psychopathologies, all because they missed the high-functioning spectrum aspect of the presentation. And then unfortunately, they are then diagnosed as some kind of schizophrenic process. I mean, if there's a psychiatrist in the audience, you'll appreciate that the negative features of schizophrenia and autism are phenocopies. They are exactly the same. So if you don't know autism, you're very prone to sort of leaning towards a very chronic, debilitating, poor prognostic illness like schizophrenia. A word about that anything is possible. Here's what happened with me, because these folks are so literal. And I had a father sitting in a session said to his son, anything is possible. And you know what he wanted to be? An analyst. All because for 20 years he has been in analytical treatment. And I said, that's not possible for you to do. And he was a musical savant. I said, if you put half the effort on what you're good at, so that is where comes the question about the skill set. And I always end my interviews asking, what are the strengths of the child? For two reasons. One, you can think about the future, what he could do or she could do. And second is that you can use that as a carrot. Sometimes you can encourage them in that area so that their poor self-esteem gets a little bit of a boost. So I think it's a very good question that we should ask about the full profile of strengths and weaknesses. And it gives a wholesome picture.
Efrat, you want to say something? Yeah.
I thought of something. When Leora, the mother of the autistic child, began, she began via research. She took 21 people on the autistic spectrum and 21 people not on the autistic spectrum, and she compared their visual capabilities to see if they're... And when we all met together, and you know research, it takes time, and she said, well, let's wait. We'll see the results, and then we'll know if we're going and opening our program. And Tal told her, you know, you do your research, it's okay, it's fine, and it's needed. But we'll take a commander, and if he tells us that our soldiers are doing the job just as they should, then this is the real thing. And this is what I want to say, that I'm a researcher myself. But research has its boundaries, okay? So this is an important thing that we shouldn't only lay on researchers and so on.
Dr. Menon, the work that you're doing today, what is the next level to which you're going to take it? And when would we be able to see results which can get converted to be applied with individuals with autism, which is going to have a positive impact there? I know it's very fundamental work that is happening, but it's very interesting work. And you actually, for a very complex subject, you explained it to us in a very simple manner. We know the complexity of the whole thing, but what do you think is going to be the next level there?
I think, the question you started with earlier, training and intervention. What is it actually changing? How do we look at heterogeneity of change is one area of work that we're looking to push. And we're really interested in these reward pathways and how it interacts with the language system. And does that interaction, is the degree of the circuitry change predictive of outcomes in social and language communication skills? The other is big data, to look at heterogeneity. We also touched on this. So we know that autism is a highly heterogeneous disorder. How do we use brain imaging tools to identify subtypes? And I think the data are still coming in, and the way we approach and analyze those data are also going to evolve in the next several years. How do we extract the most useful information? And eventually, can it, I don't think it's going to be fully supplanting all of these other measures, but it could inform, you could have a brain scan that actually, with a fair degree of sensitivity and specificity, separates a child with autism from a pure ADHD. And typically developing children. I think this is feasible in the next 5 to 10 years. And the third is translational research, and we're already starting to build collaborations with people who are working on mouse models of autism, because this is where you can actually work at the single gene level and create mutant models where you can look at neurobiological features that underlie some of these things we see in human brain imaging data. And then finally, I would say this is kind of a pet passion of mine, is to really build a virtual brain, which is basically you take data on, for example, of structural imaging data, connectivity data, and you create a artificial simulated data, and can you then relate this to what you actually see in the brain of each individual child? Okay. So a data fit brain, and then can you use that as a proxy system where you can actually manipulate certain, the individual elements in ways that you can't do or perturb in, awake humans who are not undergoing surgery for intractable epilepsy. Good. So these are the things that I'm most passionate about and pushing.
Good. Great. Thank you very much. Very interesting talks this morning. Let's give them a big hand. Some of you may have more questions to them. We have a session later in the day where you will be able to sit around a table with them and discuss certain things with them. Thank you very much.